All right, so altered mental status, a lot of things can cause altered mental status. It's a huge concern because the patient having this whatever underlying condition that they might have that's causing the altered mental status. It interferes with this RAS, this reticular activating system, and it's a period of unconsciousness is huge because of the fact that this RAS is in the middle of the brain, so it's well protected, okay? And of course, we want to look, why do they have this altered mental status or AMS? Because it could be very significant, okay? And we just have to start sort of figuring out why they have it. So they could be shot, drug-induced, postictal. They could have a seizure, be in that big postictal state. They could be septic. They could have different cardiac arrhythmias. They have a bradycardia, a real slow bradycardia that could cause it. A stroke could cause the altered mental status. I mean, I know there's a list and it keeps on going. One of the biggest and surprising altered mental status for me was one time, this lady was talking out of her head. I mean, she's crazy stuff, okay? And we did a D-stick, and D-stick was normal, no history of diabetes, no history of any sort of organic brain syndromes or anything like that. She turned out to have a UTI. Yeah, the urinary tract infection. The infection was so bad that it caused this crazy altered mental status. This woman was talking about stuff in the 1900s or something. I mean, it was sort of crazy. So UTIs can cause that, sepsis, stroke, right? So we start looking for it. Randy's rule for altered mental status is always anybody with an altered mental status, you do a D-stick. Anybody, right? What about that nursing home patient that you pick up and you look at her paperwork and it says dementia? So she normally, her past medical history tells you that she normally has an altered mental status. The nurses at the nursing home tell you that, yeah, she's in her normal mental status, but it's altered. If you follow my rule, what do? D-stick. Always do a D-stick. Let's rule out the simple thing first, hypoglycemia, right? And so rule hypoglycemia out, always do a D-stick. You never want to take a patient to the emergency department that's altered without a D-stick. Most of the time, you always want to get a D-stick. It tells you a lot of good information as far as, if they're hypoglycemic, hyperglycemic. All right. The monitors, once it falls below the glucometers, once they fall below about, I think it's 40, 30, all it says is low. And then once it goes over 500, all it says is high. But otherwise, it's going to give you a number. 80 to 120 is the typical normal range for the blood glucose. But here, as you're sizing things up on this patient with an altered mental status, you're sort of being that detective. You're looking at their medications, looking at their environment, see if anything in their environment could be causing it. What about their illness? What about their past medical history? Is it trauma? Is it medical? So there's a lot of things that you need to do. If you find a patient that is on the ground and it's unwitnessed how they got there, consider C-spine. Okay, you don't know how they got to the ground. Right? If it's witnessed and they tell you how they got to the ground, then that's something else that you have to consider. But unwitnessed, you don't know how they got to the ground. ABCs always, again, assess the need for oxygen. Do that good secondary assessment. Gain as much information as possible. Right? Good set of baseline vital signs might tell you something. And what were they doing prior to? If you can get that information. So, I mean, there's a lot of questions in altered mental status. You know, if the patient is altered, then where are you getting this information from?
Bystanders.
Yeah, I mean, somebody else, right? Because if the patient's altered, then they're not a very reliable source of information. So, look at that. Bystanders. What were they doing before? You know, get a timeline with that as well. You know, is trauma, you know, do they have obvious signs of trauma? Respiratory pattern, are they breathing fast and deep, which is a respiratory pattern for hyperglycemia, right? Kussmaul respirations, we'll get there if you don't remember that. Fast heart rate, are they tachycardic? Unequal pupil size, that's a sign of brainstem herniation. Right? They may be fixed, real small pupils, pinpoint pupils. What's that a sign of?
Drugs like cocaine.
No, opposite.
Oh, opioids.
Opioids, right? Cocaine, big dilated pupils. So you look at their pupils. You ever see that? Discoloration around behind the ears and in the eyes. This is a trauma thing we'll get into later. Behind the ears. You guys are in anatomy. What's this process that's right here?
Oh, we never learned about that.
No, we don't.
Called a mastoid process. All right. And you have bruising, and we'll pick this up when we get into head injuries, but you have bruising here in the mastoid bruising, which is also called battle signs. Back in the day, when they used to fight, they figured out that they had this big rock on a chain, and they could twirl it around in the air and hit people in the head with it. And through, I guess, attrition, they found out that people that got hit behind the ear died faster than people that got hit elsewhere, because it fractures the base of the skull. So this mastoid bruising, or these battle signs, as it's the slang term is called, is a sign, as you can see it, of the base of the skull fractured. The same way with here, the discoloration around the eyes. They call them raccoon eyes. That's the slang term for it, but it's periorbital bruising, and it's also a sign that the base of the skull is fractured. It's something we'll pick up in head injuries again. Okay, skin. It's supposed to be warm, pink, and dry, right? The cold, clammy, the diaphoretic. Abnormal flexion or extension would be posturing, or do they have decorticate or decervic posturing? Okay, that would go along with the unequal pupils. They have unequal pupils. You know, one pupil's dilated, one pupil's fixed, right? Or means constricted, and then they're posturing. Then they have a severe head injury, probably a fatal head injury. Posturing is their last sort of, the body's last sort of ditch effort to live, you know?
Why does it do that? How does that help them?
It doesn't. It's just something that the nervous system does as they die due to head trauma. So you see people posturing. More than likely they're up here. It's all done. They have a pretty good head injury. It's just that sort of like agonal respirations. You know, sort of a last ditch. It's not really any good. It's just something that they're doing. Sort of their last sort of event in life that they're going to do. They're posturing, agonal respirations, unequal pupils. You know, you hear that expression, they're walking towards the light. They're not walking toward, they're in the middle of it. Okay? They're probably going to die. Okay? Abnormal vital signs. The skin tells you a lot, like we just said, the pupil size, stiff neck.
Good afternoon, Jaguar Nation. This is Dr. Marshall with a few reminders when we have Spirit Days. We're gonna remember that we're coming to a school and everything that we wear should be school appropriate. Some of you have on some fabulous superhero things today. Some of you took it just a tad too far. We'd like to remind you that things like very, very, very tight tights and things like that are not appropriate for school unless you have some shorts or a skirt covering it up. Let's make sure that we're taking care of our business and doing things right. Tomorrow is Twin Day, so you can twin it on up with a friend. Wear your jeans, your same shirt, same shoes, whatever you got to do to be a twin. That would be absolutely appropriate. But let's make sure when we look in the mirror, we go, oh my goodness, that's fabulous. And not, man, I wonder if I'll get by with that today. Because the answer to that is no. Mr. Perkins just told me, no, we're not going to do that. So please make sure that you're taking care of your business and that you look in the mirror and that you say, yes, I am showing school spirit. Yes, I am school appropriate. Yes, I am awesome. Have a great day.
That honestly didn't even sound like Dr. Marshall.
Right.
She was too calm.
Stiff neck, neck stiff,
Woo!
meningitis, right? So your patient can touch their chin to their chest. You know, that would be if they're unable to touch their chin to their chest, then that's a sign of one sign of meningitis. Lacerations to the tongue, seizures. So you see a lot, even loss of bladder or bowel control. They're incontinent. It's seizures. Most people who have tonic-clonic seizures are incontinent to the bladder. So that's one sign. Here we are to the glucose readings, right? That we talked about. Do a D-stick always. So our care for someone with altered mental status, make sure that we evaluate the need for spinal immobilization. ABCs always, suction. So when we say maintain the airway, what we really mean is anything dealing with the airway. Evaluate the need for oxygen, suction, OPAs, NPAs, right? All that is under that umbrella of maintaining the airway. Positive pressure ventilation. We have to bag this patient. That's under airway. Position them. Remember, they're unconscious. They can't tell you they're about to throw up. So you want to make sure if they're not in spinal restrictions, then you would put them in a recovery position, right? Spinal restrictions, you can't do that. So, but you would have to be prepared to log roll that patient over in suction if they started to vomit, and then transport. So find out as many things as you can, why they have this altered mental status, eliminate as many things as you can, okay, and then transport them to, as you're doing this, transport them to the hospital. That way you can fill in the doctor and the nurses when you get to the hospital and say, this is what I did, okay. One of the first things that they're going to ask you is for a D-stick. All right, so be prepared for that. And then always reassess. Are the mental status changes getting worse or better, right? And document everything as you're going through. Okay. Questions there? So next time we'll pick up stroke, seizures, right? Little syncopal episodes.